Good morning. Can you hear me okay on Zoom?
Yes, ma'am.
Great. Thank you. All right. Welcome to Geriatric Medicine Grand Round. We have a fantastic speaker today that, as you know, some of our fellows help us with Grand Round scheduling, and Sheehan reached out to Dr. Grant to come and speak with us, and I'm really glad she did. Dr. Grant is a Chief Hematology Oncology Fellow based over at Fred Hutch right now. She's a geriatrician. I didn't know, so we had another geriatrician here, and this is great to find out. She did her internal medicine residency and geriatrics fellowship at the University of Pennsylvania before coming here for her HEMONC fellowship. And right now she's on a T32 with Dr. Abkowitz, and she focuses on how geriatric syndromes can impact folks with multiple myeloma, and particularly cognitive impairment is the big focus of that. So I'm really excited to hear what you have to say today, and I'm just very excited to meet another geriatrician at UW. So thank you for coming.
Thank you. All right, so good morning, everyone, and thank you for this opportunity to just come here and chat today with you a little bit about one of my favorite topics, is really looking at the role of geriatric assessments and other frailty measures in oncology. And for this talk, I have 4 main primary objectives. I think you'll meet some additional objectives as I go through this talk, but really the first is going to be to review the epidemiology of cancer and aging. Then we're going to understand the impact of age-related factors on the outcomes of older adults with cancer, as well as review the role of geriatric assessments in oncology. And finally, we'll touch a little bit on frailty and its role in oncology care. So I think whenever I'm talking about geriatric oncology, it's really nice to set the stage for us to understand just how much of a burden this is. So when we think about cancer, cancer is the 2nd leading cause of death in the US, and it's second only to heart disease, and you can see that this is a very close second. When we look at age-specific death rates, what would be expected is seen here is that as you get older, the highest mortality rates are seen in those adults who are over the age of 65, with the highest mortality being in those over the age of 85. Many of you are probably familiar with this chart before in terms of the estimated population growth as it relates to those who are over the age of 65. When we look at between 2016 up until 2060, it is estimated that the population over the age of 65 is going to almost double. So if we take a step back and we look at this not only from a national perspective, but also from a global perspective, we can see here in the areas as you go from light pink to dark red, this represents a change in the population over the age of 65, where you can see that between 2015 in the graph above and 2050, you can see that there is going to be a marked increase globally in the population over the age of 65, with the highest concentration of these patients being seen in Europe, Asia, North America, as depicted on the graph. So finally, when we think about all of this, we know that the population over the age of 65 is increasing. We know also that cancer is the leading cause of death for the US. But when we take a look also globally at the estimated number of cases occurring, you can see here in this publication in 2019 that North America sits somewhere in the middle, and the most marked change for the new cancer diagnoses will occur in China. So if you combine this between China in males and females, there's going to be a 300% growth in the number of older adults being diagnosed with cancer. So these numbers are really, really large. When we think in oncology about some of the distribution of some of the common cancer histologies that we see in our practice, we can see here for 2019, there will be an estimated 2 million new cases of cancer diagnosed this year alone. And for the top histological subtypes, these are lung cancer, prostate, colon, and breast. And then there's this big other category where other fits all of your melanoma, your lymphoma, your leukemia. But if we look specifically for older adults, where we define that as age greater than or equal to 65, you can see the top 4 are again represented. But then the other part is that we see melanoma occurring in about 10% of our new cases for 2019. So one of the things that you may ask yourself is, we know that the population is aging, and one of the things that we're seeing is that the growth of the patients over the age of 65 being diagnosed with a cancer is also increasing. And so the question comes about, why is this cancer more common in older adults? In this paper in Cell in 2013, this is a representation of the many factors that occur, or aging factors that occur at the cellular level. And here you can see factors such as telomere attrition, as noted here. You can see cellular senescence, which is a big one, stem cell exhaustion, genomic instability. And it's thought that there is a complex interplay of many of these factors to regulate or to result in normal aging. And a breakdown in any of these domains essentially could put the host at risk for developing cancer. So when we take a step back and we want to know, okay, these things are happening at the cellular level, but what about the physiologic level? So what are the things when I am seeing a patient or my colleagues are seeing a patient in oncology that we need to be mindful about in our older adults that are happening normally, but may impact our decisions as we are thinking about treatment? So you can see here that essentially aging, and this is just normal aging, it affects all organ systems. So from CNS all the way to the bones. So for us, especially when we are prescribing our drugs, the things that we are worried about is, are there drugs that are hepatically cleared? Because you can see in aging, you have decreased drug clearance from the liver, decreased blood flow. Same thing with the kidneys, where there's an age-associated reduction in GFR, and also this can affect our drug clearance. So this becomes very important for us. The other is bone density. So for diseases such as myeloma, which is a disease of older adults, and it primarily affects bones, there's already an age-associated bone loss that can occur, which results in decreased bone mineral density, and this can increase the risk of developing fracture. So all of these things are really important as we are seeing these older adults in our clinical practice. So what are some of the factors that we think about in oncology, and for me, geriatric oncology, that potentially impact treatment decisions and the prognosis of older adults with cancer? So historically for us in oncology, many of you probably, if you've ever had exposure to our patients, hear us talk a lot about performance status. And performance status is historically measured on 2 scales. So this is named the Zubrowd scale, but this is also the ECOG performance scale, which is the Eastern Cooperative Oncology Group scale. And the other popular scale is Karnofsky, which is abbreviated as KPS. And so for Zubrowd, you could imagine here, as you get a higher number, this is usually associated with more disability. Karnofsky is the reverse, where the higher number means you're more functional. And as you go down, you get more and more sick and essentially much more disabled. So what are the advantages, and why is this so appealing for us in oncology to assess these patients using performance status? Well, the first is that this could be patient-reported, so we can ask the patient themselves to self-rate their own performance status. The other is that it's provider-reported. It's quite easy to ask these patients as they come into clinic, and it's easy to assess. So we all want to know, do a tool where it's easily assessed and manageable. So what are the disadvantages? So what we found is that this is actually an unreliable measure to really assess the patient's overall function in the older adult. And the key thing is that it assesses only a single domain. So I'll show you in subsequent studies, but essentially when we ask about performance status, we're not thinking about what is that patient's ADLs like at home. What are their IADLs? Do they have any deficits? Because performance status doesn't capture that. This is performer dependent, and so oncologist to oncologist or other providers, they may rate a patient's performance status differently, depending on, how they interpret these findings and the questions that are asked of the patient. So some other prognostic considerations in older cancer patients. So essentially, the domains that are mentioned here are really taken from the comprehensive geriatric assessment. And I'll go through each of these and think about some of the impacts which they can have on our cancer patients. So key ones are comorbidity, cognition, functional impairment. When we put that other geriatric syndromes there, we're really incorporating things such as polypharmacy, falls, whether they have osteoporosis, and other syndromes like delirium that may fit into there. So one of the key things I started by saying is that for us in oncology, historically, a lot of our treatment decisions, clinical trial eligibility has been based on performance status and also age. I really like this study and this slide because it really drives home the point that aging is heterogeneous. And what it means is that when we see our patients, we need to be age aware, but that should not be our driving force in terms of making our clinical decisions. We need to do a better job at separating out chronological age and what the patient's functional age is. And this is demonstrated in this large study here by Lowski et al., in which they looked at thousands of participants, and they gave them essentially these surveys where they asked them to report on their health status. And what you can see here is that even though there are patients who are under the age of 65 at the top, you can see that only 48% of patients rate their status as excellent. And for us, that corresponds to ECOG performance status of less than 2. And so when you look at the second graph, what you can see is that those who require help, no help with our supervision with IADLs or ADLs, that there's relative preservation of that group all the way across until you get to age about 80 to 84, and even then, about 79% of people still need no ADL or IADL assistance. And even at 85 and older, 56% of these patients are still independent. Then when you look below, looking further at whether there's any limitation of housework or ability to work, you can see that across the age span, that there's really a preservation of the independence in this domain, apart from those who are 85, where even so, you're still seeing well above 50% of people are still remaining quite independent in their ability to work. And so what this tells us is that when we see that 75-year-old in clinic, we see that 55-year-old in clinic, that 75-year-old may be in a much better shape functionally than that 55-year-old. And so we really need to do due diligence and assess them beyond just age or just beyond their performance status. So when we think about comorbidity, as we pull out some of these key domains here, comorbidity is defined as the presence of 2 or more medical or psychiatric conditions occurring in an individual. And the difference between comorbidity or multimorbidity is that for comorbidity, it usually occurs within the index disease. So for us in oncology, we reference comorbidity because we're talking about cancer. So cancer, and we're thinking about the other medical conditions that actually exist in the setting of cancer. So some of the commonly used measures of comorbidity in oncology are the Charlton and the HCT-CI, which I will talk a little bit about later. But essentially, there are several other tools that have been developed to measure comorbidity, as you see in research trials, but these are the 2 that we would most often refer to, and also form part of our frailty indices that we'll mention later. So why is comorbid burden important? So in this study, this was a large study done at WashU by Picarillo and his team. And essentially, the goal of this study was to look at 27,000 people with a new diagnosis of cancer. And what they wanted to do was to assess what was their comorbidities that were present, and then how severe these comorbidities were. And they actually used another comorbidity score called the ACE-27, which was also developed at WashU to grade the severity of their comorbidities. But in essence, the takeaway point from this is that as you get older, you have an increasing likelihood of having a comorbid illness. And then with increasing age, the severity of that comorbidity also increases. So again, this is something where we are thinking about our patients with oncology, and you're thinking you're not only seeing patients with an isolated diagnosis of cancer, but rather these patients are likely to have other comorbid conditions that we need to be mindful of. So what is the link between comorbidity and outcomes in oncology? And so several of these studies, as mentioned here, have shown that there's links to decreased survival, treatment-related toxicities, higher healthcare utilization. So we talk about things such as the time it takes in terms of the number of ED visits, the number of ICU admissions, inpatient hospitalizations, and then things like need for institutionalization, where we're talking about transitioning from that care where they may be living from independently in the community to maybe an assisted living, to maybe a nursing home, and then overall reduced quality of life. So you can imagine these are patients who are quite medically complex. They are oftentimes going in and out of the hospital setting, and these patients often suffer from poor quality of life. So in 2012, the AGS on the right here on this flow diagram actually came up with a framework on how to approach older adults with multimorbidity. And one of the key things I like for this is that they underline some of the key terms that we should be mindful about. So I think the first thing is to think about the primary concern for the patient. I would say for a complete review in a patient with multiple medical conditions, and we're seeing them in oncology, is often difficult. And so one of the key things is to focus in on a specific aspect. And so I'll give an example of this. If we're seeing a patient with myeloma who also has diabetes and they are treated with insulin, one of the key treatments for myeloma is dexamethasone steroids. And so for us, we may focus in on that particular medical illness at that point because we want to know, is their diabetes well controlled? When I add high-dose steroids, am I going to make their diabetes worse? What is going to be my backup plan? How am I going to manage this? Do I need to involve other specialists, primary care, geriatric medicine, internal medicine, endocrine, because I'm likely to be making things worse for this patient? So the other is always in these patients with multimorbidity is to consider patient preferences for them, because cancer may be occurring in the setting of multiple medical conditions, and for them, their priority may not be their cancer. So we need to always think about patient preferences. And then evidence is always a good one, and there is evidence to guide us in our treatment decision. What about prognosis? So cancer is occurring, but the patient has diabetes, high blood pressure, coronary artery disease, and COPD. What is the overall prognosis from all of those other medical conditions that are existing? And then think about interactions among treatments. So we talked about the myeloma, steroids causing worsening of the diabetes. Can it be beneficial or harmful for the treatments that we are proposing? Communicate with the patient and their relatives. And then really important here at the bottom is to reassess. So I like to think of things as a time-limited trial, especially in these older adults with multiple medical complexities. I think of things where if we come up with a decision about treatment, we're going to assess at various intervals to see whether our treatment is working, see whether it's still feasible, and see whether this patient is still having a benefit from the original treatment plan, and readjust accordingly. So if we think about comorbidity scores, at the beginning I mentioned that there are essentially two comorbidity scores that we use a lot in oncology. We use the Charlton and we use the HCT-CI. And this is very typical of a case that we would see in referral at our center. And so this is a gentleman who has high-risk MBBS, which is a bone marrow failure syndrome where the bone marrow stops working. And essentially for these patients, after going through first-line therapy options, the treatment is really a transplant, and this is where you take a donor stem cells and you give that patient. So he is coming in to be evaluated for this transplant, allogeneic meaning donor. And we see that he has multiple comorbidities, and you're asked to estimate his survival post-transplant. So which predictive model would you choose? And so for this, it would be the Sorrow Index, also known as the HCT-CI, and it's called Sorrow because it was named after the PI for this particular project. And so this tool was actually developed here at the Fred Hutch, and basically the Sorrow Index is derived from the Charleston comorbidity. So the first step in creating this tool was to first apply the Charleston to the transplant population, so all patients undergoing transplantation, allogeneic, for a blood cancer diagnosis. And then what they found is that those with actually high CCI scores greater than 1 was a very, very small percentage. And so,
Sorry. Go ahead.
Was a very small percentage with CCI scores greater than 1. And so what you see here in graph A is basically showing you the non-relapse mortality. So this is death occurring from any other cause other than disease progression. And you can see that those with high HCT-CI scores greater than 3 had higher non-relapse mortality. And this was better in terms of predicting non-relapse mortality as compared to CCI over here. And then in C, this is looking at overall survival from the time from transplant. And as will be expected, those who had higher HCT-CI scores greater than 3 actually had an inferior survival. And this was better able to predict both survival and non-relapse mortality better than the Charleston. And so the go ahead.
Dr. Grant, do you know if there's any type of index or prognostic indicator that incorporates their social support system? Because I know at least for the organ transplant, there's an assessment, but how does that get incorporated into their mortality?
Yeah.
Because it would assume that that probably has some predictive value as well.
Okay, so the question is whether or not there are any of the indices actually incorporate social support system in predicting mortality. And I would say the answer is no, at least for any of the tools that we use in the transplant. This is purely comorbidities. It actually includes 17 comorbidities, and it is scored from 0 to 29. So we don't have any that we actually use currently in oncology that includes social support. So I think it's excellent.
And part of the reason is that you wouldn't even get a transplant unless you had social support. So it's a pretty homogeneous population in terms of social support, where if you require a caregiver before you won't get a transplant unless you have a 24-hour caregiver afterwards.
Yes.
Right after the transplant.
Right.
Yeah.
So
it's kind of like weeds out for transplant. So here on the right, what I did is for the case that we presented is just to calculate this online, and I use MDCalc. So this is a calculator available for where we can just plug those numbers in. And this is just a snapshot of what that could potentially look like when you plug in those numbers. Here you will get a score. Then it will give you an estimate at the bottom here of their non-relapse mortality, 1-year overall survival, 3-year overall survival. And the reason that this is giving you an age-adjusted HCT-CI and whether it's defined or not, this has not been adapted a lot. Actually, age is not incorporated into the initial HCT-CI score. And so right now what we use is just the plain HCT-CI, which takes into consideration all of the comorbidities that I mentioned before. So as we go along, as this talk unfolds, what I'll do is we'll pull out a lot of the domains from the geriatric assessment and review some of the pivotal studies that have been done that really support assessing these in patients with a cancer diagnosis. And so as we turn our attention to functional status, when we think about functional status, we think about this mostly by assessing ADLS and IADLS. And here in this study by Repetto et al., which was done by the Italian group, they looked at patients who had a diagnosis of blood cancers or solid tumors, as we call it, and they really wanted to know whether there was any benefit of adding assessments in geriatric domains to performance status, whether that would change any of the potential predictive abilities. And so what they did, in addition to assessing performance status, they assessed comorbid burden, ADLs, IADLs. They did depression screening by GDS and cognition screening by mini-mental status examination. And so here what you can see, remember we talked about that theme of having a good performance status, that's an ECOG score less than 2. You can see that despite patients being considered to have a good performance status, that 13% of them still had more than or equals to 2 comorbidities. A whopping 37% were IADL dependent. Impairments by MMS was 27%, and those with GDS impairments, so depression screening, was 31%. When they looked at the distribution according and they combined this for both sexes, you can see across the age groups divided by your youngest old and your oldest old and your very old, you can see here that there is still IADL independence recognized here in patients who are in about 58% of patients. But as you get older, the IADL independence actually decreases, given a total of about 52% of people in total who were IADL independent. And if you think about the reverse of that, it's about 50% are IADL dependent, or 48%. Similar trends for MMS normal, so 72% of people had a normal mini-mental status, so about 31, as we mentioned above, had a mini-mental status that was potentially impaired, so 30%. So in essence, from this study, what this really led us to understand is that despite people having a good performance status at the time when they are diagnosed and starting treatment, as assessed by ECOG, there were other age-related factors that the ECOG performance scale just could not pick up. So we couldn't pick up, whether or not this patient had an abnormal MMSE or whether they were IADL dependent, because this was not captured by the performance status. So as we turn our attention to cognition, I think cognition is an interesting one because for cognition, most of the time we often think about just memory. Are you able to recall this item? And we just think about one single domain. But I like this diagram because it reminds me that cognition actually incorporates these 8 domains here. So attention, concentration, executive function, processing speed, language, memory, psychomotor ability, and visuospatial ability. And I think about this as I think about the patients that we see in oncology and some of the complaints that patients have. So these are not uncommon complaints. Patients come in after cancer treatments or during treatments and they say, I just feel as if I can't concentrate. I'm so forgetful. I wasn't like this before. I'm just not as sharp as I was before. I'm in a fog. I can't tell you how many times I've heard this from patients. I feel as if every day I'm just in a fog. I can't multitask. I'm confused. I just feel as if I have chemo brain. And that's a word that we throw around so very often. And it may seem trivial, but if you think about someone who is an accountant or a professor or, someone who's accustomed to working at a higher level, and then they can't multitask, they can't crunch their numbers, you could imagine the impact which this could potentially have on their ability to function at work, to function at school. And so we need to really be mindful about these potential complaints. So this is a very complex conceptual model around cognitive functioning and what happens in terms of patients who are actually having cancer treatment. And so you can see that in this model, it's not just the cancer treatment impact that you're having. You have all of these subcategories here. Is it like sleep difficulty? Is it fatigue? Yes, the cancer diagnosis is important, but then there are all these other factors. So what about their psychological status? So anxiety, depression, distress. What about other modifiable factors? Physical activity. Some of these non-modifiable, such as gender, the socio-demographic factors, which could impact cognitive function, and then education. And then at the cellular level, as we mentioned previously, we have these biological factors that can also play a role in aging and ultimately affect these patients as we see them and think about cognitive functioning. So what is the impact of cognitive impairment in this in our population? So this graph on these curves were taken from a paper that looked at patients coming into an internal medicine clinic, and these patients were actually followed quite long, just over 3,000 patients. And they wanted to see whether or not the presence of cognitive impairment and the severity of cognitive impairment would be correlated with survival. And what they actually showed when they administered this mental status performance survey is that those who were classified as having moderate to severe impairment depicted here had a lower probability of surviving out to their endpoint, which was about 14 years. So overall had an inferior survival compared to those without impairment and those with mild impairment. And so if we take some of that data, and we know in terms of the mortality specifically, other things in other areas we mentioned previously, quality of life is a big one, performance at home, school, and work, as I mentioned. So thinking about cognitive impairment and the impact on decision-making, so when we're counseling patients about whether they're eligible for a clinical trial and we're handing them a stack of papers, and they have to read through them and understand the information and then truly sign informed consent, is there any impact on their cognition that could potentially impair that process? Or the other is thinking about our treatments that we give. So again, I'll reference myeloma, where we treat with a drug called lenalidomide, an oral drug. In order for the patient to get this drug, the patient has to call the pharmacy, Celgene, that makes the drug. They have to complete a survey every cycle, and then they have to have that medication mailed out to them and follow the instructions on that bottle to take it. And it's not a daily pill. Sometimes it's once for 14 days on, 1 week off. Then sometimes it's 3 weeks on, 1 week off, or you may be changing it, and maybe every other day. So these are complex instructions to give to patients, and so it may be difficult for patients to follow this. So I'm telling you that I see patients in clinic, especially my older adults with myeloma, giving these instructions is not an easy task. Go ahead.
Can I just interject? So I work at the memory clinic. I can tell you right now they're messing it up. So I have every single time I prescribe a medication that has to be titrated up or down, the caregiver must.
Yeah.
And they're not supposed to have cognitive.
Yeah,
I get a message. We did the titration wrong. We ran out too soon. I mean, this happens almost every time.
Yeah.
So I worry every time there's
yeah.
anything, every other day dosing or days on, days off for just the general population. I just,
yeah.
So this is
yeah.
Black people are studying.
Yes, yeah. So definitely I will say this is it becomes very complex, and it's even going to get worse because a lot of our treatments are oral pills that patients take at home. And so really trying to figure out how to assess medication compliance in these patients, especially if you're worried about cognitive impairment, is going to be a big issue. So this is a study that really, when we think about cancer-related cognitive changes or cognitive impairment, this has largely been studied in the breast cancer population. This was published by Arti Huria, who unfortunately passed away tragically last November, but did a lot of work in this area. And this is a pilot study looking at patients with non-metastatic breast cancer, and these were all older adults. They did a neuropsych battery at baseline, which consisted of many standardized neuropsych testing, but they also included a geriatric assessment. So one of the things that I always get feedback from geriatricians when I was in the geriatric world is that in oncology, we use the term geriatric assessments very liberally. And so we are not referencing your standard comprehensive geriatric assessment. Usually when we talk about a geriatric assessment, it's an assessment that combines some of those domains. And so for this one, this was mainly ADLS, IADLS, and comorbidity, performance status, MMSE, and GDS. So it doesn't give the gold standard, so I just want to make that distinction here. The purpose of this study was really to look at longitudinal changes in cognition, and here, the way that they assessed an abnormal cognitive test was whether they scored more than 2 times below the standard deviation, below the norm. And you can see when they assess patients baseline, then they assess patients 6 months after chemotherapy. So you can see that you'll have 29% of patients, this is a small pilot study, actually had a reduction in their cognitive status, so their cognition declined. When they looked at the geriatric assessment measures, as I mentioned previously, ADLS, IADLS, KPS, Charlson, and GDS, There was no statistical difference between those who had a decline and whether they had similar changes in their other measures on the geriatric assessment domains. Overall, there was an improvement in their functional assessment in chemotherapy, breast cancer scores. This is a validated and quality of life questionnaire, and this is not unexpected because one would expect before treatment, you're not having any treatment on board, your disease is active, but as you get treated, your disease starts to respond, you finish up your therapy 6 months after you recover, that your overall quality of life should start to improve about 6 months after. So that's not unexpected to see improvement in their quality of life rating. So what about transplant? So I'll always give a transplant spin because I'm more of a hematologist than an oncologist, but from a transplant perspective, Surjala, this was actually done at the Hutch. They wanted to assess what the cognitive changes were in patients, again, undergoing allogeneic, which is donor cell transplant, all for blood cancers. Baseline testing was done at before transplant, day 80. Usually for us, day 100 is a benchmark because that's the time we start thinking about mortality. So the people that survive to day 100, and day 100 is counted as the day 0 is the day you get your cells back, and then 100 days from that day. So that's where we are counting from. And then day 365, and they wanted to see how those changes in cognition, again, assessed by neuropsych testing, changed over time. And one of the key things to point out here is that they use various tests as outlined here. But what was interesting is that before transplantation, up to 80 days after, you can see that there was a decline, okay. So here at day 80, what you can see in all of these measures, that there were increasingly more patients who had a decline or impairment in these domains. But then when they were followed up to 1 year, there was improvement or recovery in most of these patients who are listed here in each of these domains. And one of the things I want to mention is whenever you look at studies where people are undergoing donor cell transplants, the population is usually a younger population historically. The diagnosis is usually AML, acute myeloid leukemia. The older adults included in there are going to be patients with MBBS. And even so, the number of people who are actually truly going to be over the age of 65 undergoing ALLOS are going to be pretty small. And so if you remember here, the mean age was 41 for this population. And the reason that's important is because with allogeneic transplantation, the mortality from transplant is pretty high. And so you have to be a really fit 65-year-old or 70-year-old to even, and I'm not even sure if they would consider at 70. So you have to be really fit, low comorbid burden, good reserve before they would consider it. So that's why in this study, even though these patients are younger, they were still able to show that there were changes in their neuropsych testing throughout. So in essence, what they summarized, adult survivors of transplant experienced a decline at day 80, and this improved by day 365. This was a follow-up study, so they actually followed these patients for 5 years. One of the things I will say with this is that about 35 to 40% of patients actually died before this point. The reason is that these patients are transplanted mostly for AML, and the 5-year overall survival is still pretty poor, so usually about 30%, 40% range for AML, and so there was about 40% of patients that died by this point. But in essence, what they showed was that 5 years, for those who they were able to assess, that function continued to recover. They did note the domains in which function was recovering, but there were some people, about 41% of survivors, when they used this global deficit score, who still had some persistence of their mild neurocognitive changes. So one of the things this study did not do was to link this to any end of quality of life kind of data, or it didn't measure any geriatric assessment domains, as was explained in the Heterogeneity. So this was purely looking at markers or measures of neurocognitive impairment and how they change over time. So what are some of the future implications? So when we think about counseling patients or patients that may be coming back to your team for follow-up, for just general medical issues, it's good for counseling survivors post-transplant to say, you may have changes in your memory, or you may have changes in the way you think, or you may feel like you're not, multitasking, or you feel in this fog, but with time, we expect that those changes will start to improve. And then you may identify those, and I know this may be controversial a little bit, about neuropsychological rehab for patients, but also thinking about other supportive strategies. So is this patient showing signs of impairment sufficient that they may need a caregiver to help with that complex medication direction that we are giving in clinic, and whether they need additional supportive strategies. So this is a study from our group. So this is from me. We are looking primarily in the VA population. This is unpublished. We conducted a retrospective study at the VA, really looking at veterans who underwent autologous. So this is from their cells. So this is a different population than the allogeneic world. The difference is that for myeloma, a disease of older adults, these patients are older. You can see, as I'll show you in the next slide, our patients actually are older than the allogeneic population. But this is data from 76 veterans, and when patients are undergoing transplant at the VA, they actually undergo a comprehensive neuropsych evaluation within 14 days of transplant. They have these additional measures. As I mentioned, we use the HCT-CI quite often because we use this to predict their survival. ADL and IADLS is recorded by our psychologists, and then performance status is usually done by KPS. And we wanted to see whether or not the presence of any of the impairments in these domains, in particular, if a patient had abnormal MoCA scores, would impact the time to first unplanned hospitalization or length of stay on the transplant service. And so what we found is that the majority of patients, as would be expected, had a good performance status like KPS, which is 80 to 100. And so most of the patients were in that area. Those with CCIs of greater than 1 were about 56%, but we had only a very small portion of these actually had CCI scores of 2 or above. 14% with more than 1 IADL impairment, and interestingly, these are not age-adjusted or adjusted because this is preliminary data for us. 52% had abnormal MoCA scores. We didn't find an association between whether you had a MoCA score that was considered in the abnormal range using unadjusted cut points. But we did find that the older age was associated with longer length of stay on the transplant service. And the reason that is important for us is because our transplants are all outpatient, unless the patient has no caregiver or they have end-stage renal disease and require hemodialysis. And so this is just exploratory work for us to really try to understand, first it brings light to the benefit of having a psychologist, which a lot of centers do not actually have. And so it brings light to the importance of having these testing. And then for us, our next steps are to really figure out, how can we figure out a way to follow these patients more longitudinally to see what long-term changes in terms of quality of life these impairments may have on them. So we're going to switch gears a little bit. So we're moving along on some of the geriatric syndromes. So we touched on ADLS, IADLS, comorbid burden, cognition, and now we're going to talk a little bit about falls. And so this was done by my mentor at WashU, a systematic review of falls in older adults with cancer in 2015. And essentially, the goal was to review the literature and to see whether they can first identify what the prevalence and risk factors were for falls in cancer patients, and to determine whether this differed according to community-based patients. And so what you can see here, when they divide it into outpatients and inpatients, and I will say the inpatients usually were patients in the hospice setting. About 20 to 33% of patients had a reported fall within the 3 to 12 months prior to entering the particular study. Some of the risk factors for falls are some that you are aware about from the community, normal community dwelling individuals, but having a cancer diagnosis actually was a risk factor. Age above 80, women were more likely to fall and injure themselves, and then ADLs, IADLs impairments. And then, more importantly, chemotherapy. They noted that chemotherapy, which was neurotoxic, or androgen deprivation therapy, which we use in prostate cancer, actually put patients at increased risk for falls. And ADT is one that we do know that has persisted, that this is truly a risk factor for falls. When they look for inpatients with cancer, including hospice patients, so older age again, Medications, importantly, so antipsychotics, opioids, and corticosteroids. Again, I think this is going to be a function of the fact that a lot of these studies were including patients who were in hospice, and so you may see a reflection of the drugs that are commonly used while they are inpatient hospice. Anemia was a risk factor for falls also in these patients. So some of the factors were previously known and some additional ones for the cancer population. This systematic review was later updated in 2016, and essentially they wanted to really look at what was the prevalence of the injurious falls, so the number of people falling, how many of those had injuries, and about 29 to 74% had been reported in the 31 studies that they included in this systematic review. Additional risk factors for falls that we didn't mention previously that they identified was osteoporosis. And interestingly, for patients, the rate of fracture, about 3.2 to 78%, which is a pretty high interval, actually had a fracture related to their falls. The last question they had was whether or not there was an impact of falls on subsequent cancer treatment, and they did not identify an impact on cancer treatment. So what about transplant-related geriatric syndromes? So this is a recent publication this year, looking again in the transplant population undergoing allogeneic for blood cancers. And what they wanted to see is after transplant, what was the prevalence of, the incidence of geriatric syndrome. So the patient actually gets their cells, and then they want to follow them up to day 100, that pivotal mark for us. And they wanted to see what geriatric syndromes develop, what are some of the risk factors for delirium and falls, and what is the impact of delirium and falls. And so they really focused in on these two curves. I focused on delirium and fall primarily. And so what you can see here is that from day 0, which is counted as the day you get your cells, you have an increasing risk of developing delirium. And I think this is not unexpected because these patients are all inpatient, getting chemotherapy. You know, they could become quite ill during this immediate post-transplant period. And then this kind of plateaus out here the further away you are from transplant, so heading towards day 100. And then similarly with falls, you can see here around that day 10 mark, it starts to steadily increase and then plateaus out to day 100. And overall, they looked at the link between falls and overall survival, which was interesting. Those who, this was all retrospectively done at Memorial Sloan Kettering, those who had a fall actually had an inferior survival compared to those who had no fall. So again, some of the information that we looked at before, risk factors that they identified for delirium, but one of the things that may be important for a transplant is the graft source, so that's where the cells came from, the HCT-CI, the comorbidity index that we talked about, transplantation time period, and interestingly, they put falls in there also for delirium development. PIM meaning potentially inappropriate medication use, which we know is associated with falls. This was one of the key takeaway points from this study is that delirium, actually the presence of delirium was associated with non-relapse mortality for both delirium and falls. So those who had delirium had higher incidence of non-relapse mortality and also falls. And it's debatable as to whether or not this is, you know, what could be the potential mechanisms for this developing. So again, just mentioning some of the risk factors as we mentioned before. So putting it all together, we talked about functional assessments using ADLS, IADLS, we talked about performance status, we talked about age, cognition, and we talked about some of the things that could occur post-transplantation, such as delirium and falls. And now we want to know, how do we think about this clinically in oncology? And so to start with this, first, we do have quite robust data that tells us that a geriatric assessment or geriatric evaluation is beneficial for older adults with cancer. This was a systematic review published last year, including approximately 40+ studies. Here, the key findings from this study is really to identify whether a geriatric assessment, and the term is applied again loosely, where C means that this is where the patient was referred to a geriatrician for the usual standard CGA. A means that this is performed either by the oncology specialist or it was performed by an allied health nursing specialist. And M means that the patient was seen and evaluated and had geriatric assessments in a multidisciplinary clinic. And what you can see here is they wanted to know whether geriatric assessments altered either recommendations for oncologic treatment or non-oncologic treatment, meaning if you identified an impairment in their geriatric domain, that there were recommendations for treatment. And here what you can see is between 26 to 100% of patients after having a geriatric evaluation actually had recommendations for additional non-oncologic treatment. So that could be polypharmacy, optimizing their comorbidities, cognition, functional limitations, and working to improve that. And then similarly for oncologic treatment, you can see here that between 8 and 54% of patients actually had an alteration in their oncology treatment plan. So meaning if you were recommending a more intensive chemotherapy regimen after they saw someone had a geriatric evaluation, this was then changed to a less intensive treatment. So similar to what was mentioned before, so the geriatric assessment did have benefit not only in the non-oncologic treatment recommendations, but also in the oncologic treatment recommendations. And so what is the overall impact of GA that has been pulled from this study and some additional work? So it can help to allocate treatment according to GA. So in a patient who has a GA and they may be likely having falling into an area where they will be considered frail, that may be someone where you would consider monotherapy, so single agent chemotherapy versus combination. The GA in this systematic review was found to improve treatment completion and tolerance, lower rates of treatment-related toxicity, and in this SR, they did not find a major effect on healthcare utilization, survival, and quality of life. Despite this systematic review, there was then a robust review of about 68 studies put out by our group, the Cancer and Aging Research Group, and they published a guideline last year. And essentially, the take-home point is that adults over the age of 65 who are getting chemotherapy, they should have a GA routinely performed to identify vulnerabilities that we do not capture routinely in oncology assessments. So predicting chemotherapy toxicities is a big one for us. So we talked about how we can implement GAs, but we have some tools available that can tell us after we've made that decision about implementing chemotherapy, what is the patient's risk of developing toxicities. So we can see here, this was done by Heria, again, and her group, older adults, again, starting chemotherapy, checked a GA, and essentially the endpoint was whether they developed severe toxicities. This is the risk prediction model that was ultimately developed where you can score between 0 to 25. And here you can see factors such as falls, hearing impairment, limited ability to walk one block, decreased social activity. So this is where the chemotherapy toxicity comes in and not on the transplant side. That also is used to give you an overall score. In essence, this is the new model here on the left, your right, left. Sorry, and what you can see here is that with an increasing score out of a possible score of 25, this should be, that the risk of the number of patients developing toxicity also increases. But when you compare this to those who had just performance status, again, we're talking about performance status and how inferior it is for predicting toxicity, you can see that these are physician-rated performance status, and it didn't do as good as a job as predicting toxicity as over here. So another score that was developed is the CRASH score. Again, this is developed to check the development of grade 4 toxicities in both blood and non-blood conditions. Similar concept, but different parameters are included in this score. This makes it a little bit more burdensome for us to use in clinic, so the preferred modality would be to use the CARG score or the Heria score. The reason is that this includes a full MMSE, which some providers may not want to do, and also this nutritional assessment, which is a little bit difficult, and this chemotox, which is a combined score. This is their validation data, again, showing similar that when you have a low score on this, your toxicity risk is at the bottom here, and then as you go up, the risk of toxicity increases. And this is just showing how they derived the model and their external validation that was done. So despite talking about all of this and saying, you know, these are all tools that were developed when we use chemotherapy primarily, many of you know that the landscape for oncology is shifting rapidly, and with that has come a whole host of new drugs and ways we treat patients. This is just to bring some attention to the fact that immune checkpoint inhibitors are now a big part of our reality, and we really don't know how these drugs fare in older adults. And so more and more you're seeing these papers coming out as they retrospectively try to go back and look at the subset of older patients in these trials who've had these drugs to see exactly how they do. So with our new treatments, they bring new challenges to us. So are new cancer therapies such as immunotherapy and CAR T-cell safe in older adults? Maybe, but we don't know completely. What about developing toxicity risk prediction models for immunotherapy? I'm sure this is probably going to be coming down the pipeline. Could more adults be eligible for treatment now that we have these newer agents, presumably with better side effects? And then how do we draw the line between undertreatment and overtreatment? So finally, I will just mention two slides to just mention frailty, because I like these two editorials that came out last year, thinking about frailty as this reduced state of physiologic reserve in which when a patient is exposed to stressors, they then could have all of these, potential outcomes here, which are falls, delirium, disability, increased care needs, and admission to hospital. And so there have been many attempts to think about how do we incorporate frailty into our oncology care. And I like this one that says, are we ready for this? Is it prime time for this? And I would say the answer is probably no at this point, because there are challenges. The model at the bottom here really tells us the Freed model, which is well known, which the presence of 3 or more of these will give you a phenotypic evidence of frailty. But how do we translate this into actual clinical practice? And so this is an example of a paper that actually came out last month, and they really wanted to develop a frailty score. And here, what you can see is that they use a simplified version, which has caused a lot of controversy in our world, because they essentially went back to say HCT-CI and ECOG performance status is a frailty scale. And what we showed before is that frailty is very complex. And so we don't believe that just applying a simple scale like this is going to capture the essence of what frailty truly is. So these were their outcomes of interest. They wanted to see about overall survival, progression-free survival, and they concluded this was positive for them because they analyzed this data from a previous trial, and that using ECOG, CCI, and performance status actually is considered the frailty scale. So challenges with frailty scales, as I mentioned, lack of consensus on the definition. How do we measure frailty? We know the Freed model, but there are so many out there. There are probably about 70 or 80 different frailty scales available. How do we choose which one? And a lot of them are disease specific. So if we had to summarize everything and we needed to just put together a framework for the geriatric assessment, when we see a patient with a new cancer diagnosis, we really want to think about doing a geriatric assessment. If there are identified vulnerabilities, then we want to go ahead and treat those, develop individualized treatment plans, consider life expectancy and prognosis to other geriatric syndromes, balance the risk of treatment-related toxicity, and always incorporate patient goals in the decision-making process. So finally, these are some models of care for geriatric oncology. There's geriatrician referral, which is often difficult because there will never be enough geriatricians to see all of the patients. Oncologists screen and refer to identify if there are any impairments. Dually trained geriatric hematologists or oncologists like myself, I will say this number is increasing, but there's still never enough of us that we can be embedded in a single institution. And then multidisciplinary clinics, which are actually on the rise. And here is a summary of some of the multidisciplinary clinics nationally. You can see the majority of these are actually concentrated on the East Coast, but these are considered to be growing in popularity and really a great way to bridge that gap between geriatrics and oncology. So in summary, the population is aging. The GA use could result in improved outcomes and informed treatment decisions. Cancer treatment in older adults remains very complex, and we need to have continued efforts to promote a multidisciplinary or multi-specialty approach to care. And then ongoing research is still needed to identify the impact of GA-driven interventions and risk-stratified approaches on cancer-related outcomes. And here are my acknowledgements. Dr. Wiles, who's my geriatric oncology mentor at WashU, Dr. Jose Garcia and David Garcia. And these are some additional resources for our groups that we participate in, that they have a lot of resources about how to evaluate older adults with cancer. And with that, I will take any questions if we have time. Thank you.
Dr. Rand, yeah, I was just curious, is there a growing body of literature that looks at treatment outcomes, not so much geared towards cure, but stopping disease progression in older adults, meaning that, for example, for an older individual, you're not going for cure, but you're looking for stopping disease progression instead?
So the question is whether there's a growing body of literature around studies looking at how you go for stopping disease progression. I will say from a geriatric assessment standpoint, there is one current large trial, I believe it's called the PROMISE trial, that is currently designed in a similar way, I think, at what you're getting at. And the design of this is essentially that you do include patients who are frail and have best supportive care, and you are comparing them in that arm to people who actually are considered as not fit and intermediate fitness, and then you're assigning treatment based on that. So essentially for those patients, the expectation is already that their disease is advanced, they're frail, you're not going for cure, but you're basically trying to see what the impact of the geriatric assessment would be in stratifying patients in that way.
Yeah, taking it more of about a palliative approach.
Yeah.
Kind of treat.
Yeah, and so that arm in particular is using GE to assess into that, to randomize to that group, and then they are actually getting best supportive care versus monotherapy or doublet chemotherapy. Sorry.
For the study that you referenced in the slides, showing that, geriatric assessment impacted treatment decisions, treatment course, et cetera. Just to clarify, was that a geriatric assessment started at the beginning before cancer treatment was started?
Yeah. So all of these studies included in the systematic review. So the question is whether the geriatric assessments were performed prior to the initiation of cancer treatment. And so all of the studies in the systematic review, these are patients who are evaluated for geriatric domains just at the beginning of starting their cancer treatment.
So there wasn't any follow-up, like repeat geriatric assessments or anything like that during the course of the treatment, in the studies in the systematic review? No.
So these are all people. So that is always a question as to whether there is a repeat geriatric assessment, and that's the question that comes up often, is after we've identified these vulnerabilities, then what is the interval at which we repeat that? And I think that is a clinical decision, but in these studies, they are focused primarily on performing a geriatric evaluation at the time of initiating systemic therapy. Mm-hmm.
Regarding immune checkpoint inhibitors, I think you made the case clearly that we need answers urgently to these questions. Until that happens, what we are actually seeing is these treatments are being offered to people who are much less functional than historically. And I worry that some of those people don't really know what they're getting into, and the effects of those interventions for the worse may be somewhat delayed in time.
Yeah. Yeah.
How would you advise us to manage the discussions around intervention in this situation before we have the data?
Yeah. So the question is, how would I recommend that you manage our discussions surrounding immunotherapy use in patients who may have more functional impairments than what we are used to when we are considering other forms of cytotoxic chemotherapy? And I think, this is one of the discussions where it requires an open conversation. First, to say that clinical trials that were done studying immunotherapy were not necessarily done to include older adults. We really don't know fully how the data has not matured where we know how this immunotherapy is likely to affect an older adult. But again, going back to this idea of having these time-limited trials where we can trial giving you immunotherapy, and if you develop severe toxicities, then that would be the point where we would consider that you would stop it. But I usually counsel patients, for me, whenever I'm talking about immunotherapies, I say this was studied in a younger population. We are seeing that patients, older adults, like this paper that I showed you with real-world data, that they're able to tolerate it. But again, we don't know if you are likely to have these side effects, and you just need to be really mindful of that and really monitor those patients closely.
I would just add that one of our fellows at the Hutch actually looked at this question regarding use of immunotherapy. It was specifically for bladder cancer and the use of immunotherapy among patients with a lower, or with a higher, worse performance status. Because historically, as Dr. Grant mentioned, that's usually very prognostic for cytotoxic chemotherapy, and given the side effect profile and this thought that immunotherapy is better tolerated, the thought would be, well, maybe you could give it to people who are less functional, and it looked like it was, we should right now, with the data that we have, we should use the same criteria, that we shouldn't be treating patients that we wouldn't with cytotoxic chemotherapy, with immunotherapy, just with this perception that it's better tolerated. But the outcomes are very similar. And so patients who don't have a good performance status, they don't do well on immunotherapy or cytotoxic chemotherapy.
Thank you.
Thank you.
Thank you. Yeah, thank you so much.